About 19% of the country's population lives in areas considered rural. Our guest and her allies work to close rural health disparities, and they're celebrating some recent legislative victories.
This money is being proposed to be used in some really important ways, because we do have very challenging situations in many of our rural communities in terms of health, like I said, health outcomes and life expectancies.
Carrie Cochran-McClain is the Chief Policy Officer of the National Rural Health Association, and it is the largest organization of its kind serving rural communities.
I'll be honest, we were hearing from members and folks in the public about the awards potentially having more political influence than I believe they ultimately ended up. CMS moved quickly to put out a what I thought was thorough notice of grant funding given the time frame, and they stuck pretty closely to the criteria that were laid out in that.
This is Conversations on Healthcare.
Well, Carrie, welcome to Conversations on Healthcare.
Thanks for having me.
Oh, that's great. Maybe we could just do a recap of some of what happened last year. First, the bill known as H.R. 1 proposed billions of dollars of cuts to the Medicaid program. Tell us what was the specific threat to rural hospitals in that bill.
Sure. Rural hospitals, there are about 2,000 of them across the country. And on average, they operate with much lower margins, meaning they have less kind of cash at the end of the day than most facilities across the country. Of our rural hospitals, about 50% of them have negative operating margins, meaning they have to come up with other resources to make ends meet at the end of the day, end of the year. And when you think about the fact that the Medicaid population is about 20% of a rural hospital's kind of group of covered lives, any kind of cut, especially when it's one that's up to 20%, sometimes even more, will have a big impact on those facilities. And so what we were really voicing is that as you are thinking about changing Medicaid policy, whether it's to how states are paid or how who is eligible for coverage, you need to realize that it's going to have rippling effects to the providers who are caring for them in rural communities.
Carrie, is a hospital that's in a rural area a rural hospital, or is there a special designation they have to get to be a rural hospital?
That is a great question. We have made rural hospital, well, like everything in healthcare, let's be honest, we have made rural hospital payment very confusing. It all dates back, I won't go too far into the history lesson, but it all dates back to when Medicare moved to the prospective payment system. And PPS rates are based on kind of an average that does not really adequately consider the low volume and high fixed costs that rural providers have to meet in order to provide care, right? You just have fewer patients, but you're paying for the same types of services, types of costs related to providing those services. And so we have, over the last probably 30 years now, come up with all sorts of different ways to recognize unique situations of rural providers. So we've got critical access hospitals, we've got sole community hospitals, we've got Medicare dependent hospitals, we have low volume hospital designations, and then we have kind of outpatient equivalents with our rural health clinics. And then there are many federally qualified health centers or community health centers in rural areas as well.
Great. Well, we're going to talk more, I think, about the rural health clinics and the community health centers, but I want to go back to the hospitals for a moment. And that figure you put out a little while ago of 2,000 rural hospitals, is that what I heard? That is a very impressive number, and yet given the distance may still not be enough. But your organization has stated that some of those cuts we just discussed will be offset by the Rural Health Transformation Program, which obviously is a big topic of discussion in healthcare circles all over the country, rural and urban, I think. Tell us how this fund came together back while Congress was debating H.R. 1.
Sure. Well, I think there was some great recognition of the potential impact of Medicaid cuts on safety net healthcare providers everywhere, including rural. And as part of that conversation, Congress came up with the Rural Health Transformation Fund, which is $50 billion over a 5-year period of time. That's really meant to transform rural healthcare. The challenge is the way the statute is written and most definitely the way the administration is implementing it, is that the funds can go to a much broader set of activities, all of which I think have some level of validity in terms of needing to address the longstanding disparities we have in health outcomes in rural areas. But they aren't necessarily, those dollars aren't necessarily directed directly to rural hospitals and the potential losses that they will see during the Medicaid cuts. And so we're in this position where it's a little apples and oranges. The Kaiser Family Foundation estimates that over the 10-year period that the bill was scored, there will be $170 billion in federal losses under the Medicaid program. Even if that entire $50 billion for the transformation fund goes directly to the providers who will see those losses, it's not going to be enough to offset it. And there's really no guarantee with the way the program's being implemented that those dollars will even go to providers most in need. Those decisions have been left up to the states to make for the most part.
Well, that's a very interesting point to make. $50 billion sounds like a lot, but they cut much more than that. Tell us a little bit about what you see in that process. State governments are coming together. They're sending off to CMS. Here's our proposal. CMS is, I think half of the money is going out by some allocation formula. The other half will be by CMS's decision. Tell us what you're seeing in some of those applications. Is there anything exciting happening outside of its shorting the vital programs that need money, the rural hospitals and rural health centers as well? But what are you seeing in the proposals so far?
Yeah, and again, it's a little bit of a catch-22 because this money is being proposed to be used in some really important ways, because we do have very challenging situations in many of our rural communities in terms of health, like I said, health outcomes and life expectancies. So we are seeing a big portion of the money going towards, or being proposed to be used towards, really thinking about rural hospital and provider stabilization. So that is part of it. We also
But that varies by state, right?
That varies by state. And then sometimes it's even a little bit more specific. So we are seeing some specific call outs for things like there's a significant number of our rural hospitals who have closed their labor and delivery services. So we are seeing where states may be choosing to stabilize labor and delivery, or think about how they get that care to a community. So it might not be the entire hospital, it might be one element of the support that they provide. We're seeing a lot of focus on workforce. That was one of the 5 strategic goal areas within the program. And so efforts looking at grow your own pipelines. We know data shows that if a practitioner is from a rural area, or if they're trained in a rural area, they are 4 to 5 times more likely to practice in that community. So thinking about how we really grow and invest in our training capacity in rural areas, and we've seen lots of good examples of that. We also have seen a heavy emphasis on virtual and technology-enabled care. And you heard this a lot from the administration. There's a lot of interest in remote patient monitoring, telehealth expansion, thinking about how we really lift up our digital infrastructure through investment. Some of that is going to take some investments in basic EHR capacity and interoperability capacity, but some of it is a little bit more, what we're seeing is even a little bit more kind of cutting edge, even some AI kind of enabled care. And then I would say the last bucket really is around the MAHA agenda of making sure that we have community-based whole person care. Thinking about care coordination. There's a big focus on community health worker expansion in a number of states. There's focus of behavioral health and telebehavioral health services. So all, like I said, important to making sure we have strong well-being in our rural communities. And we're excited about kind of the initiatives and innovations that may come out of this. But it is going to take some oversight and keep our eye on the ball on the broader infrastructure, the day-to-day reimbursements to help the providers survive as well.
Right. Sounds like we needed a plus, not a and/or situation.
Yeah, right. Exactly. Yes.
And I've read some critics say that the Rural Transformation Fund, lacks transparency and has the potential for politicization, to which I think I would say if you put $50 billion into play, we certainly are going to probably hear about
politics,
about those issues. But there's some thought that states that were friendlier perhaps to some of the administration's policies might have received an advantage. What is your group stand on this pushback?
Yeah, it's a good question. There was a lot of concern, I'll be honest. We were hearing from members and folks in the public about the awards potentially having more political influence than I believe they ultimately ended up. CMS moved quickly to put out what I thought was thorough notice of grant funding given the time frame, and they stuck pretty closely to the criteria that were laid out in that. Some of the funding allocation was based purely on kind of the statutory formula that required funding to go to more rural states or states that had certain rural indicators.
Sparsely populated areas.
Right. Yes. Some of the funding was, and this is the discretionary funding. So there was $25 billion that went equally to everyone. Alaska and New Jersey, it got equal amounts in that kind of baseline funding. And then there was another $25 billion that was discretionary. And within that discretionary, there are three kind of categories. One that had the rural indicators, one that was the state's proposal to transform rural healthcare and how valid that CMS and the reviewers felt like that proposal was. And then the third area was around really incentives to help states implement state level policy changes in areas that the administration thought were important and helpful to rural areas. So some of those did have a political leaning to them. Others are long-standing things that folks in rural areas have been working on. So an example of the long-standing would be some of the scope of practice challenges or battles, I will say, that we typically see between guilds. Yes.
Battles between guilds. It sounds like the Middle Ages.
Yeah, right. Well, and states could choose whether they put in to do those state level policy changes. So there are some states, a number of bluer states, that decided not to do any of those or do a handful. There are some states like Alaska that I think may have put in almost every policy proposal idea that we saw in the NOFO. I mean, they're tackling a whole lot at the state level. And CMS was pretty direct that at least the staff that we heard from, it was don't bite off more than you can chew, in that they are going to be holding states accountable to being able to implement these things. So it will be interesting to see if any of those funding levels shift as we get into implementation, because there is an opportunity for CMS to pull funding back or not fund at the same level moving forward if they feel like the work isn't being done as proposed.
I think, go ahead, yeah. Clarify the 25 billion of the 50 billion is in this first round of applications. And then the second the remaining 25 will be a little bit later, or it's all going out?
It all goes, technically it's all awarded now. So the states got their kind of first year funding level that was pulling from those two tranches of funding. And then the funding will be allocated over a 5-year period. So it's being done in what's called a cooperative agreement in federal. If you're familiar with federal funding, it's an opportunity. It's an agreement type that has both the government and the states kind of having some input into the direction of the work. And assuming states are meeting kind of their proposed work plan and goals, CMS will fund kind of at that same level for the 5-year period.
Got it.
Margaret, we've heard, and Carrie just mentioned accountability and implementation. I think what we've heard is sometime in October, CMS is going to make an evaluation about whether or not the state is going to get the same level of money.
Not a lot of time.
So they really want to hit ground running. I want to shift a little from these dollars into something that you've been working closely with the congressional champions to build support for improving care in rural America Reauthorization Act. I'm wondering if you could shed a little light on what that program is and what are its of Congress approving it.
Yeah, great question. So the program that you were talking about, Improving Care in Rural America Reauthorization Act, there is within the U.S. Department of Health and Human Services an office called the Federal Office of Rural Health Policy that has been around for 30 plus years, really serving as a voice for rural healthcare within HHS at the federal level. And one of the core kind of umbrella set of programs they operate are called the outreach programs. This bill would reauthorize that suite of outreach programs. And the reason that we believe so strongly in getting this bill reauthorized is that these programs are so unique to the federal government. They give rural communities the ability to come together in a consortium model. So it requires 3 partners within the community to come together, and the grants fund work that is deemed to be needed by the community. So the topic of the work, while there are definitely themes across the country, is community identified. So we see a lot of work in kind of emerging areas that are unique to communities. They're 3-year, almost kind of pilot demonstrations or programs to get the work up and going and on the way. And we see incredible sustainability rates in the 90s, high 90s for these programs once they're funded. So it is, I think, one of the few places where communities can say, I have this specific need, and we really see the collaboration in moving it forward. And it's just been so successful. We are thrilled that it has passed out of committee in both the House and Senate, and are very thankful for our sponsors, Senator Scott and Congressman Carter, in leading that. Right now, it's we were hoping for a hotline, but maybe a floor vote. It's so hard to predict what's going to happen in Washington these days, but we are hopeful to see it get past the finish line this Congress. Because the authorization did expire at the end of last year. So now we're in that space of hoping that Congress decides to appropriate it, but there isn't an official authorization for that program any longer.
Well, I think everybody's on the edge of their policy seats probably this week, waiting to see what happens. But meanwhile, life goes on in our country, rural and urban. And certainly, I would say for the last 25 years, the opioid crisis has been a crisis across America, and certainly rural communities were hit very hard as well. First with the prescription drugs, and then with fentanyl, and of course, alcohol has always been there in our country.
Longstanding,
as a scourge. Is that still, from your perspective, as states are looking to really invest in programs, is that crisis still commanding attention in terms of investments that are needed? We still have the problem. I think we've made some good progress in treatment and control of some of the substances, but we still have a big crisis, I think.
Yeah, I mean, you said it perfectly. There is most definitely still a need in this space. In SUD treatment, I would say across the board, with opioids continuing to kind of take the lead at that. But you're right, we have alcohol use, we have higher use of methamphetamines and some of those types of drugs in rural areas in certain pockets of the country. The thing that's interesting with the OUD and the opioid crisis is that while nationally, I think there have been improvements in OUD indicators, we are seeing slower progress in our rural communities, which is concerning. And in some cases, CDC is reporting even widening gaps between rural and urban. So overall, the news is good, but we'd like to see more progress in our rural communities. And, I think a lot of that is due to some of the persistent challenges we have related to accessing treatment and some of the structural barriers in getting treatment and prevention around behavioral health services. Again, we're hopeful that there may be an opportunity through the Rural Health Transformation Funds for states to really hone in on this. We also have been really looking at legislative solutions that continue to support kind of those rural specific community-based interventions, as well as telehealth being a way to get access to behavioral health, including OUD in our rural communities.
And teletraining for
yes,
people.
And teletraining, yes. Yeah.
Well, Carrie, I want to get into the weeds a little. I wonder if you could just shine a light on the fight over the attempts to expand site-neutral payment policies, and tell us a little why the association is so opposed to such site neutrality.
Yeah, so site neutral, if you can take a step back, it is always interesting in my perspective to see how markets drive what healthcare looks like in this country. And the conversation around site neutrality, like many issues, I think plays out differently in a rural context. You heard me at the top of the hour talk about kind of our rural hospital vulnerability. One of the challenges we see here is that rural hospitals rely more heavily on our outpatient services. If you think about the kind of care that's provided in a rural community, it tends to be lower acuity, more primary care based. And our rural hospitals see as much, if not more than 75% of their revenues coming from outpatient services. Unlike, a larger tertiary care center that may have many more kind of inpatient based revenue. So when you are talking about with site neutrality, kind of making equal or lowering the hospital outpatient payments to match what's in a physician's office, that really could have a disproportionate impact again on our rural areas, given how much outpatient services or how many outpatient services they're doing. The other thing to keep in mind is with the way that our markets have evolved, we see fewer and fewer freestanding physician practices in our rural communities. More doctors and advanced nurse practitioners and PAs are getting out of the business of having their own practice for a whole range of reasons. And in many instances, the hospitals are the ones who are picking up those services or operating those clinics if the doctors are closing shop. In that case, if we were having to move to a site neutral model, we have significant concerns about hospitals' ability to keep those sites open, which may cause further access challenges if there's no one there to operate the local physician's office because they've closed up shop. So I think there are some legitimate questions about, from my perspective, about why you should have to pay more for certain services in certain settings. The truth is, in a rural hospital setting, it can be more expensive to get that care, but it may be the only place in your community you have access to it. And so we believe that as those site neutral conversations are happening, that we need to account for that when we're really thinking about beneficiary access in the long term.
Well, this is so important. And I have to say, I also have such admiration for some of our rural states. Maine is one of them, where the creativity that's gone into how they connect people to the right service, to the specialist and the tertiary services, as well as rural, is just incredible work. So great to shine a light on it. And along those lines, we're really interested in your collaboration with the National Association of Rural Health Clinics. And this is a great time, I think, for us to ask you, for our listeners, to maybe clarify community health center, federally qualified health centers, rural health clinics, rural health centers, rural hospitals. Maybe just shed a little bit of light on how do you move from one to the other, and what's the essential difference? They're all there to take care of people, but what are some of the essential differences?
Right. It's alphabet soup, isn't it, in healthcare? So a rural health clinic, I think when you're talking about outpatient care for the most part, right? Like if you're thinking about a clinic or a physician's office, primarily in a rural context, you're talking about a rural health clinic or a federally qualified health center or a community health center. Can get into the weeds of the difference between the FQHC and the CHC, but they are different models in that the community health center program has they receive grants from the federal government, and they have certain parameters they have to follow in return for getting that grant funding. So they have to provide care to anyone who comes in the door. They have to provide a sliding fee schedule. They have a very patient-driven board of directors. Correct me if I've gotten any of this wrong, but it's a little bit of a different model. So you see them, you may see a network of community health centers, but they tend to be, kind of a community-driven model of care. And they provide things like oral health and behavioral health, as well as primary care. A rural health clinic may do those things, but they might not. The rural health clinic designation is a designation under Medicare that recognizes, again, the challenges with providing primary care in a low volume setting. And so it is a payment designation that sites who qualify get under Medicare and in most states under Medicaid. A lot of them do have sliding fee scales and do provide high levels of kind of charity care, but it's not a requirement in the same way that the health center program is. There are just under 5,500 rural health clinics nationally. And in rural areas, data from actually the National Association of Rural Health Clinics shows that nearly 2 in 3 rural Americans are served by those sites. And with an RHC like a community health center, there's access to primary care. That's really their model. They do, depending on the site, may have some behavioral health, may have other more specialty services. They also have a team-based model. So you may see a physician, but they're also required to have a non-physician practitioner on site. So an advanced nurse practitioner or a physician assistant of some sort. And there are quite a few provider-based rural health clinics that may partner with a small critical access hospital, which is our smallest kind of rural hospital, 25 beds or less. So that might be the outpatient site. A provider-based rural health clinic might be an outpatient site for a small critical access hospital.
That's very good. Great. We'll capsulize that and send it out to our colleagues.
It's a lot.
Just a quick question before we wrap up. You were talking about the markets drive so much of healthcare. I was just thinking about the Medicare Advantage program, of course, which is available across the country, but they just got notice from CMS that the amount that they had expected, maybe in the 6% range, they were at 0.9%. Any thoughts about the implications that might have?
Oh man, our members have lots of thoughts about Medicare Advantage. I will say, while we haven't seen as high a penetration in rural as urban, I think it's definitely getting there. We're just under 50% of rural beneficiaries being in Medicare Advantage. I will say that Medicare Advantage plans, in some cases, really can offer some unique set of benefits for beneficiaries. They can also offer kind of cost sharing and cost reductions in a way that you might not see under traditional Medicare. But from our experience, the provider interaction with Medicare Advantage plans has been very challenging, especially around MA plans' use of kind of some of the prior authorization, delays, denials, appeals. All of that is just so hard for a rural, under-resourced provider to have to sift through and deal with. They may have one person in their billing department, not a team of however many we see in larger facilities. The other thing that we're seeing a lot with Medicare Advantage is that they are driving beneficiaries away from certain services. So in our critical access hospitals, there is something called a swing bed stay, which allows someone who may not be an acute level of an acute inpatient, but may need like swing bed, like SNF or post-acute services. If there isn't a skilled nursing facility in their community, they can stay in the critical access hospital in that swing bed and do their rehab and get better. We're seeing MA plans deny that to a lot of rural beneficiaries throughout the country because they don't want to have to pay the critical access hospital rates. They'd rather ship them to another community and a skilled nursing home facility. So those are kind of just some examples of the challenges. We always are telling our members, and I know our providers are talking to their members of really making sure that the beneficiary understands kind of what they're getting and what they're losing when they sign up for an MA plan, because it isn't the right fit for everyone, and it definitely is not always the right fit for the provider community.
Well, Carrie, thank you. And I think it's a given that we have to have Carrie back.
Absolutely.
I'd be delighted.
Issues we didn't get to. All of our questions, and so much will be evolving over the course of this year. So thank you for joining us today.
My pleasure.
And thank you to our audience for being here. Just a reminder, subscribe to our videos on YouTube and find us on Facebook and X. And please share your thoughts and your comments about this program. Take care, everybody, and be well. This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.